Welcome to the webinar, Elevating Smiles with Veneers. The lecture is being presented by Wendy A. Clark, DDS, MS, FACP, and we will begin shortly. And with that, it is my distinct honor to introduce Wendy A. Clark, DDS, MS, FACP. Dr. Wendy Clark completed her undergraduate training at the University of Georgia and earned her doctoral degree from Marquette University School of Dentistry. She then earned her master's degree in clinical dentistry and her certificate in postgraduate prosthodontics from the University of Alabama at Birmingham School of Dentistry. Dr. Clark practiced prosthodontics for 7 years with Team Atlanta and lectured nationally on a variety of topics, ranging from smoking cessation to dental implants. She was named the leader in continuing education by Dentistry Today in 2017. And currently, Dr. Clark is full-time faculty at UNC Chapel Hill Department of Prosthodontics. And with that, it is my pleasure to say, take it away, Dr. Clark.
Thank you, as always, Jessica, and thank you everybody for attending. Today we will be talking about veneers. I'd like to start by introducing you to my patient. He came in, this young man had just finished school and he was entering a career as a banker, and he had felt that his smile made him look too young. And he wanted people to take him a little more seriously. And so he came for an initial consult for veneers. And just looking at the occlusal view, you can start to see a few things. He has congenitally missing laterals, canine substitution, arch forms a little bit flat. So we can start to see some of the things we can and can't do with veneers, and that will help start guiding us on our treatment plan. Again, he just wanted some teeth that made him look a little bit older. He didn't like the gap between his two front teeth, and he wanted his smile to be a little bigger and a little brighter. So to see if he's a candidate for veneers, we start with something called the trial smile, and we'll walk through this in depth, but this will just give you kind of a broad overview. In his case, I did a conventional wax up that you can see on the left. We make a putty matrix over that wax up cast, and then we seat that in the mouth over the patient's teeth. And so we'll use a bisacryl resin. And then that way we can kind of test our prototype before we move forward to the next steps. This is what his trial smile looked like in his mouth. So now he can kind of see that the proportions aren't going to be perfect because, again, we are missing the laterals. Working with a canine substitution case, we do have some limitations. You can start to see the varying translucencies, meaning that some areas the resin's a little thicker, some areas it's a little thinner. And so you can see how valuable this tool can become in the process of diagnosis and treatment planning. And because now I know which teeth are going to need to be reduced a little bit more, where the resin was thinner, I can do a more guided reduction for my preparation, meaning I don't need the same amount of reduction on the central incisors that are linguoclined as I do on the canines that are too far facial. So we can do a more appropriate customized reduction for our patients. Once we do our preparation, we get our definitive impressions, go to provisionals, very similar process to the trial smile. And then we go to our try-in phase. This is where we make sure the patient approves of the smile, that we've met all their goals, that we've communicated effectively through the process, get their approval before moving forward. And last but not least, we bond everything into place for our patient's final smile. And so this presentation will kind of walk through step by step what to expect and how to communicate with your patients. And we think about veneers often as a newer treatment. However, they have been around for nearly 100 years. They became popularized in the 1920s. They were called Hollywood veneers. And this is Dr. Charlie Pincus. And one of his patients was Shirley Temple. And at this time, they were a removable prosthesis. Bonding hadn't been invented yet, but it was basically a little veneer that would be temporarily cemented over people's teeth. And that kind of served as the guide to what veneers have become today. So how do you know if your patient's a candidate for veneers? These are our typical patients that we'll start to see. Patients with discoloration are usually kind of the number one that we see in our practice. Patients like the first one I showed you, Chris, with the diastemas, undersized teeth, like the peg lateral case in the middle, smile correction if we're trying to straighten things up or do kind of the instant ortho, you might hear it called sometimes. And last but not least, teeth with slight wear. The people that we do not recommend veneers for, so these are kind of our immediate no-goes, are going to be patients that are severe bruxers. Those are going to be at high risk of debonding. Extensive existing restorations. Once you remove the restorations, oftentimes there's not a good substrate to bond to anymore. You have a lot of exposed dentin. You have a lot of undercuts you have to bypass. So typically patients with heavily restored teeth are going to be more of a full coverage crown patient rather than a laminate veneer. The middle one, highly fluoridated teeth, is a little bit more um, up in the air and harder to tell. A lot of times now we have patients that are in areas with heavy fluoride intake or the water may be super heavily fluoridated. And in those patients, sometimes you can't get a good bond. And I've actually not seen this as much with my veneer patients as with orthodontic patients. If you have patients where the brackets keep debonding, they might be a patient with heavily fluoridated teeth. In that case, if you want to see if the teeth are too fluoridated, usually we'll do an etch test where you can etch the tooth for 30 seconds with a phosphoric acid, just your regular restorative etch, and rinse. And if you don't see that chalky appearance on the enamel, you're going to have a really unpredictable bond. Next, we have severe malposition. In these cases, they may be a candidate for some veneers, but in order to recorrect everything, usually orthodontics is necessary, either in addition to or in place of porcelain veneers. Another one that we don't think of as often, but is also equally important, is going to be patients with active soft tissue disease. When you think about kind of the rules of bonding, one of the number one things is trying to keep that area dry and isolated during the bonding process. And with heavily inflamed gingiva, it's really impossible to control the heme, the hemorrhage of the tissue. So you really want to get any gingivitis or anything like that under control at the onset before you prepare your veneers. And last but not least, this is more of an ethical issue, is patients with bleachable teeth. We have a lot of patients, or I did in my private practice before I went to academics, where they would come in and they just need a little bit of whitening and they would ask for veneers. And so those patients, you want them to go through the whitening process first to see if they can achieve their goals with a more minimally invasive treatment protocol. So as we showed in the last slide, some of these patients are not candidates for veneers directly. So in those patients, you'll want to start with some sort of whitening, either at home or in-office whitening. If it's just one tooth, you can do an internal whitening for endo-treated teeth. Some patients need complete ortho or clear aligners, either prior to or in a replacement of veneers. And they may need periotherapy to get things under control and full coverage crowns. So this is one of those grayer areas where it's when do you do a full coverage crown versus when you do a laminate veneer. And also you can do them in conjunction with each other. So if you have a patient that you're doing a smile makeover for, and one tooth needs a crown, that doesn't preclude you from doing veneers on the neighbor teeth. Especially with today's materials, and we'll talk a little bit more about those at the end. It's become a lot easier to do some color matching. You can use Emax, for example, or lithium disilicate, or even a zirconia for both crowns and veneers. And so depending on your aesthetic goals and your color matching and the color of the substrate underneath, you can start to choose a material that's going to help you achieve those aesthetic goals. And you can mix and match crowns, veneers, and even implant crowns. The main criteria, and this is probably the most important point of the whole lecture, when you're trying to determine if a patient's a candidate for veneers, they must have sufficient remaining enamel. Veneers do not bond predictably to dentin or even to composite. So this is the number one requirement, is what's the tooth structure remaining? When you think about inlays, onlays, crowns, any of our other indirect restorations, we learn about retention and resistance form when you're in your second year dental school class, because you're preparing the tooth to hold that restoration in place. With veneers, you don't have that. You do not have retention and resistance form for the most part. You're truly relying on the chemical adhesion that you get from the bonding process. So if you don't have enamel, you can't get that predictable bond. And the enamel thickness varies at various parts of the tooth as well as with age. And this is just a quick graphic of showing kind of how you have less enamel at the CEJ, and then it kind of gets wider as you come towards the incisal. And so that's important to remember as you start doing your preparations for veneers. Since you want to stain the enamel, you're going to have to be much, much, much more conservative at the cervical margin than you are at the incisal edge. And this is just a quick graphic showing that the bond strength from all enamel on the left side as you go down to all dentin on the far right. So dramatically drops and increases risk of veneer failure as you go from the enamel preparation to a dentin preparation. And even here, going from the first table to the second table, when it's half enamel, half dentin, it's almost as bad as having all dentin. So that presence of a significant amount of enamel is critical for choosing whether or not your patient can have a veneer. So when now you've determined they have adequate enamel, tooth structure is good, how do we walk through the process? Who's a candidate? How many veneers are we going to do? What material are we going to do? And the first answer to that is going to be a diagnostic workup. I always say, when in doubt, get mounted casts, whether they're digital or conventional. And for veneers, you want to make sure that you have aesthetic information as well as the conventional diagnostic information you get for your restorative cases. So as with all patients, you're going to want to start with comprehensive oral exam and radiographs. In addition, you'll need at least this full face photo. Of course, it's always more helpful if you get some other ones, but this is the one photo that you absolutely need to get for your smile design, and we'll show you why as we go through. You need nice impressions that show a nice, clear, crisp gum line. That's really important, as well as the occlusal surface. And that can be a conventional impression or a digital impression. And then last but not least, you'll need some records. As you start to get these records, you'll want to do an analysis, again, not only of the tooth structure, but facial analysis. Does the patient have asymmetries in the lip? What about the gingival margins? Are they going to need crown lengthening to achieve their aesthetic goals in addition to porcelain veneers? A dental analysis, like the first patient, Chris, that we showed, where we have some teeth that are out facially and some teeth that are lingually set. How can we kind of play with the proportions and change our preparation to accommodate those interdental inconsistencies? And then last but not least, a smile analysis. High smile line, low smile line, medium smile line is going to play a big difference in the smile design that you do for your patients. For each tooth that you're going to prepare, you want to evaluate and make sure that it's periodontally healthy, that it's endodontically healthy, and that there's good enough enamel to bond to. So make sure that there's sufficient enamel to bond. And again, our records don't have to be conventional anymore, but they certainly can be. You can also do digital. If you're going to do a conventional record, you'll want to get stone casts or physical impressions of your patient. Ideally, you'll do a Facebook transfer so you can start to do that smile design and any interocclusal centric records that you need. Virtually, you can accomplish the same thing with an intraoral scan, a full face photo that will allow you to do a digital face bow, and then whatever interocclusal record you're going to make your wax up at. Typically, if it's just a smile case where you're only doing veneers on the anteriors, the majority of those cases are going to be restored in MIP or maximum intercuspation. You're really going to only go to CR if you're doing a partial denture or some implants or opening the bite with crowns or onlays in addition to that. So the majority of your just plain, straightforward, plain old veneer cases are going to be restored in MI or maximum intercuspation. This will walk through that digital FACEBO process. So here we're starting with an intraoral scan. Again, you want to get all that same information that you would get on an alginate impression. And then we're going to digitize that, pull it into the software. Most of the software programs today will set that occlusal plane based on averages. But the full suites, you can actually import that full face photo and line that up with a scan. So you're going to pick 3 or 4 points on the teeth that will align to the scan. Here we're setting the inner pupillary, which is like the top arm of your face bow, and the midline, which is like the middle of the bite fork of your face bow. And then you'll want to pick those points, align those to the scan, and then you can actually pull that scan and align it to that full face photo. And so this is something that we can't do with a conventional wax up where you can actually see the wax up in the patient's face. And this isn't like one of those AI generated smile designs because this is actually customized to your patient and you can convert it from 2D to 3D. If you show your patient's ears in the photo, so have them tuck their hair behind their ears, you can actually align the articulator. And this is like that third point of first and second point of reference on your face bow. So you can actually now get pretty much all of the data that you would get from a conventional face bow imported digitally, which I think is really cool. If you're going to restore your patient in centric relation, you can actually scan them in centric relation. And now you have a virtual patient in CR at the correct horizontal position, the articulator aligned to the patient's condyles, the midline set and the interpupillary set. So now you know any wax up that you do on this digital wax up is going to align to that patient's face in a very predictable way, which I think is really cool. I think in private practice, this is something that's important to think about. That all this takes time, right? So you're getting, whether it's conventional impressions that your assistant or your staff are pouring and mounting for you, or whether it's a scan that you're having somebody take time to do the smile design, all of that takes time, whether it's your time or a staff time or a lab bill. So you do want to make sure that you're coding that out. The code that we recommend at least is the diagnostic cast code, which is the D0470. You can also use this D9950 code, which is called occlusion analysis mounted case, but that will allow you to kind of do that initial preliminary work to determine if your patient's a candidate for veneers. When I was in private practice, we had a lot of patients come in for consultations and then either decide not to pursue treatment right away, or once they found out the amount of work and effort that it took to get veneers, they wouldn't move forward with treatment. So you want to make sure that you do have a charge for this step at the beginning of treatment. A lot of times we would credit that towards the patient case if they ended up moving forward. So that's a way to kind of, that way they don't think about it as an additional investment, but this actually gets credited back. So let's talk a little bit about the wax up. This is going to help us decide whether a patient needs 1 veneer, 2 veneers, 4, 6, 8, or even 10 veneers. It's going to vary on their smile design and how much smile display they have and what their aesthetic goals are. So there's a lot of different techniques we can do for smile design. Kind of the godfather of all smile designs came from Christian Coachman. And you've probably heard of DSD, or digital smile design. And the whole concept went based on the patient's personality. And they had 4 different personality types with templates for teeth that they would overlay on the photographs. You would have a calibrated ruler where you know, for example, based on either your intraoral measurements or on your physical cast, that the central incisor is 10 millimeters long, and then you can calibrate the ruler to 10 millimeters. So now you know exactly how much width and length you're adding as it goes to from the digital smile design to the physical wax up. And with digital smile design, basically you say, all right, I need to lengthen this a millimeter based on the photo, and so on and so forth. Now that's become a lot more digitized. It was very conventional. Now it's very digitized. So the DSD of today is not the same as the DSD when I was first learning smile design many years ago. So let's show how that's translated and evolved to a digital wax up. And this will kind of go step by step through what I showed on that very fast video. But the key here is you need a full face photo where the patient's looking to the front, and you want to see both of their ears, both of their eyes, and the incisal edges of their teeth. So you want to kind of have your patient separate a little bit so you can follow the incisal edges. If the patient has their teeth together or their edges covered up by their lip, you won't be able to merge the photo to the scan. So that's one of those things that's key, is that the incisal edges are visible, that the patient is looking straight ahead, and ideally you'll see both ears. And when the patient looks ahead, if they cant their head to the side, that's okay. You can correct that by rotating the photo. But if they turn their head to the side, then you won't be able to align the cast correctly. So it's important that both eyes are facing the camera. And this is just an article that walks through how you can align the photos. The case that I showed you on the video and the case I'm about to show you as we go through is on 3Shape, which is a full service design software. The one in this article is on Exicad. So both of those allow you to pull the photo in and do the digital smile design with the articulator. Those are both laboratory softwares. So the 3Shape isn't the 3Shape that comes on your scanner. That will allow you to do kind of a quick two-dimensional smile design, but it can't be converted to the 3D wax up. So if you want to be doing the full digital smile design, you need to use the laboratory software, which is quite costly, but it's an amazing full service suite, but it's several tens of thousands of dollars. Exicad's a little bit more affordable. It doesn't have some of the same user ease of use in Exicad, but it's a lot less expensive. So if you're interested in doing full smile design, Exicad, 3Shape, InLab from Dentsply, all of those will allow you to do a full smile design that can be converted from two-dimensional to three-dimensional. So this case, again, we're doing it on the lab software with 3Shape, and I take a patient photograph. This is a student case, and I like to show this one because you can see that the photo's not in focus, and that's fine. It doesn't have to be the best photograph. So if you don't have a DSLR camera and you just are using an iPhone or something, that's fine. You just need a photo of the patient smiling, looking straight ahead so that you can see the incisal edges of their teeth. So here we're merging the patient's scan to their photo, and we pick the points like we showed on the video, and now we can start to do the wax up. Because this is aligned to the photo, any of the changes that we make here, we can then cross-reference in the patient's mouth. And so this doesn't necessarily look like the 2D thing that you use for patient advertising, but this is actually functional because we can now 3D print this and try it in the patient's mouth. And so there's kind of two different softwares. There's the 2D quick smile design, quick view. I'm going to sell a case to a patient. And then there's the actual three-dimensional full digital wax up that you can use for actual diagnosis and treatment planning. And they're both great. They both have their place, but the one that is here, you can't use for this. And the one that is here, you can't use for this. All right, so now we've done that digital wax up. Now we need to see what that looks like in the mouth, right? We have a photo, we kind of have this idea about what it's going to look like, but we want the patient to be able to see it and to feel it and to speak with it. So we're not only checking aesthetics, we're also checking phonetics and function. So we're going to walk through the trial smile. This is one of my favorite things I do in all of my practice. It's really saved me a lot of cases. It's sold me a lot of cases, and it's really helped direct me down the right path. So I think of all the things I do, the trial smile is one of the most ideal diagnostic tricks that I have. So in this case, we're going to make a little putty matrix over that wax up that we did. If you did a digital wax up, you'll 3D print the wax up and make a matrix over that 3D printed model. And then you're going to use any sort of temporary material, temporary crown and bridge material. We call it Bisacryl is the family, but it could be Integrity, it could be Luxitemp, it could be Expertemp, it could be the brand you get from Henry Schein or Patterson. It doesn't matter. They're all the same. So here you see we made the putty matrix over the cast, and this could again be printed or it could be a physical wax up. Load it up, go all the way around, and then snap it over your patient's teeth. And then you're just going to let that set, just like you would for your crown provisionals. And so now here we have our wax up transferred to our patient's face. And depending on how big the patient's smile line is going to depend on how well you need to clean up this little excess at the margins. You can also use this to mock up crown lengthening. So if your patient has short teeth, you can actually wax up over the patient's gum tissue. And now you're trying in to see what it would look like if you did the crown lengthening. And that can be huge in kind of showing patients what the goals can be, both good and bad. Like this is what we can actually do. These are the goals that we can achieve, and this is what we can achieve. And so my patient had a lower smile line here, so I didn't have to go too crazy cleaning up the gum line. But now we can start to see this is the goal we can achieve. And in this case, it was really important to me because she had finished orthodontics And the orthodontist says, I can't move that midline anymore. So you can see she has a pretty significant midline shift on the maxilla versus the mandible. And so I don't want to do veneers and have her finish up and say, my midlines don't match. Because now I can say, this is the best I can do with a midline matching. Does this meet your aesthetic goals? And if not, then she doesn't have to go through the whole veneer process, or she can say, okay, I can live with this or I can't. And it puts the power back in the patient's hands. But also it gives you kind of a way to set realistic expectations for your patient. This next case, I did a digital trial smile, and so I didn't do the Lexitemp. In his case, it was fully printed. And he came in, this was a younger kid he was actually in a jet ski accident, and he came in with his mom. And as a fellow mom, I recognized that she was a tiger mom. Like, she was very protective of her kid. And so I said, I am not going anywhere near this child's face with a scalpel or an instrument or a drill until we get until we build that trust. So in his case, I didn't even do an impression, a physical impression. We did a scan. And so here he was pre-treatment. Was again in a jet ski accident, had some teeth intruded, avulsed, and replaced. He went through orthodontics, and this is where the orthodontist said that they had to stop, that some of the teeth were ankylosed. They didn't feel comfortable moving some of the other teeth. So this was the stopping point for ortho. This was the best they could do. And so again, his pre-treatment smile, he doesn't even show his maxillary teeth. He's only showing his mandibular teeth. And his mom just wanted to be able to see his front teeth. So here we do our digital wax up. Again, this was done I think this one was also in 3Shape, where we do our digital wax up, we extend those teeth, we're building them out as well. And so now we can print or mill that smile mock-up. So now it becomes like a snap-on smile, where I don't have to go in the mouth and try to clean off all that excess material. I can just pop it in, say, what do you think, mom? And then she can give me her thumbs up or thumbs down, and we can go from there. This is showing kind of how that arch form was being corrected. So you see the teeth are not only intruded, but they're also palatally set. So when you look here at 7 through 10, we are building out 8 and 9 huge. Like, there's a lot of material there. So what that means to me is I don't need to do much preparation to correct this arch form. It's all going to be an additive process. And this is showing intraorally when we seat that printed trial smile in the mouth. Now I can look at the corrected arch form, make sure it's achieving my goals, and then I show his mom and make sure it's achieving her goals. Then the patient gets to see in the mirror whether or not it would achieve his goals. And she was really pleased. Again, her main goal was she just wanted to see his teeth when he smiled. And so he had a very small smile. But you can see here, he does show the incisal edges. So at this point, I say, this is what I'm able to do with a minimal prep or a no prep veneer, and make sure that she's on board to move forward with that. So again, trial smile can be super, super valuable. It shows how many veneers you need to do. So when you're trying it in, if the patient says, I want all my teeth to be white, and you show them what it would look like with 4 veneers, and they say, oh, I want it whiter, then you have to say, I'm going to do 6, 8, or 10. You can add those teeth to the trial smile, and then they can go from there. And I've done that with patients where I recommend 10 veneers because they have a huge smile and they want a big correction. And then they say, well, I only want to do 4. And so I'm like, that's fine. So I have a wax up and I can do a trial smile with 4. I add 6, I add 8, I add 10. And then the patient, again, is now in control. And they can say, I like this smile versus this smile. You can take pictures of all of them, send them home with a patient to show their spouse or their family. And then that, again, becomes a more collaborative treatment planning process. I can set realistic goals, like the cases I showed you for this is about the amount of tooth display I can show with a low smile line. This is how far we can correct the midline. This is how far we can correct the size of those canines. But all these goals are set at the beginning before I ever take a burr of the tooth. And that gives me peace of mind, because if you've done enough aesthetic cases, you've gotten to the point where you're trying to seat the finals and you can't get on the same page as a patient. And that's probably one of the most frustrating parts I ever had in private practice. And so if I can do all this work up at the beginning, set that goal and set that expectation here, I know I can get to this point. I don't know if I can get to where they want, but I know I can get here. And if the patient's okay with this, we have it documented. We have the photographs of the trial smile. We have photographs of the provisionals, photographs of the try-in, photographs of the finals. It becomes really an easy path from A to Z. Oh, and last but not least, it improves case acceptance. And to me, there's when you do the trial smile for a patient that really wants that aesthetic, cosmetic makeover, there's nothing like seeing that light in their eyes when you take the picture of them with a trial smile in, or when they look in the mirror and they see it. And so then they say, "This is what I want. I'm going to do this." And I think the trial smile for me improved my case acceptance exponentially when I started using that with my veneer cases. So now we have our candidates in mind. We know that we're going to do veneers, patients accepted. We are all on the same page. We're doing this many veneers. This is what they're going to look like. This is how much we're going to lengthen it based on the smile design. Now we can start to do the veneer preparation. There's a couple different types of veneers. We have a no prep veneer, which is when you're only doing an additive process. There are pros and cons to each type. Again, the biggest pro to this one is you're not preparing the patient's teeth. So technically, it is quite reversible. And this is what I did on the younger patient that I showed you in the jet ski accident. Um, it was something that was a no prep. I knew I could take it off if I needed to, if treatment plans changed as he got older, or if he started to have teeth shifting. And we did have to change his veneers out. So I was very grateful that we did no prep and I still had all that enamel. Um, and then it also improves some patient acceptance. A lot of people want the smile makeover and don't like the idea of losing tooth structure. Also, when you do a no prep, you know you're going to have as much enamel as the patient came in with, which again is the main key to success with veneers, right? Is having that enamel substrate to bond to. So if you don't take any enamel away, you have maximum enamel. When I do no prep cases, I usually don't use any local anesthesia unless I'm placing a cord or when I'm finishing the margins. But there is no prep, so you don't have to anesthetize for the prep appointment. The cons are really it's having a lab that knows how to do these well. Some labs are very great with conventional prep veneers, but not so much with the ultra thin or no prep veneers. So you want to make sure you identify a lab, and I'm sure that NDX can help you with that, that specializes in these thin, like contact lens type no prep veneers. They're a little bit more challenging if you haven't done a lot of veneer cases because they don't have a home. So when you think about seating a crown, the crown snaps into place, the margins are closed. It's similar for conventional veneer prep. You want to seat it, feel all the margins, make sure they're sealed. There's usually a little bit of a shifting with a conventional prep veneer, but there's a home that it goes to. With no prep veneers, they can kind of move around here and there because there's not a definitive space. There's not a definitive home for that veneer. It's like kind of like putting on a Lee press-on nail, or that shows my age. It's like an acrylic or like a nail that fake fingernail that you're putting on, and you can shift it side to side, up and down. Um, and the good news is you're not going to have to worry about open margins because there aren't any margins. But you can shift a midline, or you can cause a cant, or you can shift an incisal edge. So you want to really make sure that I would advise that you become more comfortable with veneers before doing prepless veneers, but it's a really fantastic tool to have in your tool belt. Um, the risk of over contouring and poor quality margins and kind of having that bulkiness at the gum line, that's with veneers that are made a little too thick, so they're not kind of like that contact lens veneer that where the margin finishes to like a knife edge finish line. A lot of times, my lab will make these for me, and then after I cement them, I will finish all the margins and make sure that those margins vanish. And I'll show you the tools I use to do that as we get to the finishing step. So you want to make sure that again, key element here is find a laboratory that specializes in these ultra thin contact lens type veneers. And again, case selection, highly skilled lab tech. I've done a number of prepless cases. They're probably my favorite veneers to do for a number of reasons, but again, have a lab tech that I've been working with for a really long time on these. They also have to be purely additive. So you can't bring teeth back or change shift a midline or change a line angle really, because you're really limited by what the patient has. Um, so that's kind of the limitation here is you can't do quite as much stuff. They're a fantastic solution for peg laterals, for undersized centrals, and those types of teeth. But for example, the patient I showed you at the beginning that had canines in the lateral spot, there's not a chance I could do a prepless veneer on those. It would not look aesthetic at all. So you want to know in your wax up that it's an additive procedure and not a subtractive procedure. And last but not least, when you start doing these prepless veneer cases, a lot of times it makes it um, more approachable, less terrifying if you do provide that light chamfer margin, especially right at the cervical. It makes it easier for finishing. It makes it slightly easier for seating to know that you're in your right home. If you just give a little baby knife edge chamfer margin or a finish line at the gum line. So that's prepless veneer. We also have a conventional type preparation. So if you're starting with veneers, this is a really nice place to start. This is what they go through in all the textbooks. Um, there's really excellent guidelines for how much space you need, what the margin design should look like, and everything else. And once you become comfortable with these, I'm sure everybody on this call is going to do a lot of veneers because there are a lot of patients that need these or want these. Um, and so in this case, you're going to want to make sure that you have a light chamfer all around the margin. So you want, and remember our enamel gets thinner. So you want 0.3 at the cervical, 0.5 at the axial, and then you want about a millimeter to a millimeter and a half incisal reduction. So that way we can change the incisal shade, shape, and length. Another key point is making sure that every line angle is rounded, as with all ceramic restorations. Any sharp points on the preparation can induce fractures in the veneer. And you want to make sure that you have a nice path of insertion. So what that means is you don't want to have an undercut coming back as the veneer wraps around. So you want to be able to see the margin all the way around, go back to your dental school and think about visualizing your margin all the way through. Can you tell I work with second year dental students a lot? They're some of my favorite people. Um, so we talked about the facial preparation. We want 0.3 up at the cervical, 0.5 reduction in the mid facial. And so that means that we really have two planes of reduction that we need to look at. We don't want to go too far in through the enamel of the cervical because the enamel is thinner there. So we want to make sure we're doing 0.3 at the cervical, 0.5 at the facial. All of the major burr companies now, Brasseler, Comet, all of them have these reduction burrs where these diamonds go 0.3 millimeters or 0.5 millimeters, and they come in different depths. So you can get those depth cutting burrs to help guide you if you're more comfortable with that. After you do the depth cutting burr, you're going to use this reduction burr. And you can see that there's two grits, and we'll get another picture of this on the next slide, but there's a fine grit where the margin is, and then there's a coarse grit where you want a little bit more reduction. So it makes it easier for you to do that more minimal reduction at the cervical and a greater reduction as you come down the facial. So here we're refining our margins. We're getting that reduction we need from the 0.3 and the 0.5. And you can see we have the two different planes. So this is a two plane of reduction. We have 0.3 on the first left-hand photo and 0.5 here on the right-hand photo. And this is another view showing those two grits of that diamond. So you get kind of that coarser reduction. You can actually see on the tooth on this canine, for example, how there's more grit lines visible on this portion of the tooth versus the cervical. There have been a number of studies for crown preps and veneer preps as to whether or not a coarser or a finer, like more polished prep makes a difference. I think that the more polished preps look prettier on Instagram, but it seems as though the coarser preps that you see, like where you can actually see these diamond lines, might actually help. It might help with the retention of the cement because it gives you that little bit of mechanical retention and those grooves for the cement to sink into. And so here you can start to appreciate where the margins are. We have margins here on the mesial and distal on these teeth. This is more of a slice prep, and I'll show you what that means on the next couple slides. But you can kind of follow that margin all the way around the tooth. And so you can imagine as you're seating this veneer, it's going to have a definitive stop. the interproximals are going to stop on these enamel margins here. The gingival margin is going to stop like a crown prep would at this cervical margin I've prepared. And then we'll show the incisal margin next, but it's kind of that butt joint where it stops there. So this veneer has a home. So that's the main difference between the conventional prep and the prepless, because the prepless, you can slide it all over that tooth and it makes, again, positioning a little bit more challenging. The cervical finish line should follow the gum line. Usually we recommend kind of an equigingival margin. You don't want to go super subgingival because isolation is key. A lot of times we'll finish it equigingival if patient has a high smile line, super aesthetic conscious. Finish it equigingival, place a cord, and then just lightly touch it to get down to where your cord is. And that'll help kind of tuck that margin very, very, very slightly subgingival. If your patient has a higher smile line and it doesn't matter so much, you can leave those margins super gingival. That facilitates cleaning and kind of visibility if a patient has a higher caries risk. The extensions interproximally are probably one of the harder aspects of veneer preparations because you want to make sure that the junction wraps that line angle so that you can't see that margin. So as you tuck it in, it kind of creates a hidden margin where you won't get stain that's visible or have issues that way. But you have to do that without creating an undercut as you reduce it. So kind of tucking that wing in without creating an undercut, I think is probably, for me at least, the hardest part of my veneer preparations. If you'd like to make that part easier, you can do what's called a slice prep. Again, the slice prep is a little bit more aggressive of a preparation if your patient doesn't have diastemas, because you're having to open that up quite a lot. So it's less conservative, but it also makes it more aesthetic. So you're kind of going back and forth here on balancing aesthetics and tooth preservation, and it's going to look different for each patient. If your patient comes in with a diastema that you're trying to close, the slice prep is ideal, because then you can shift that midline or that contact point however you want to do that. And so it allows you to slightly shift the midline to kind of close those black triangles, and let the ceramus have as much space for ceramic as they can. There are studies that say that they might be associated with higher survival. Others say not, but basically it's at least equivalent to a regular margin. And this is showing side by side a slice prep on this right central incisor. And so you can kind of see it on the lower view looking straight down at it, where this one has more of a defined margin here. So, and you can see a little bit better on number 9. Number 9, we have a really well-defined margin or a stop here on the distal, kind of a halfway slice prep with a deep margin here on the mesial. And then we have a true slice prep here on the number 8 central incisor, where there's not a defined margin. The ceramus could finish the margin here. They could finish it halfway through, or they could finish it up higher because they have now all the room to play. So you can imagine that's kind of an easier prep. You're just sliding right through. You don't have to worry about whether the margin's far back enough because there is no margin. It can go back as far as you want. For the incisal reduction, I think that's the easiest part of the veneer prep. We're just doing a 90-degree butt joint. You can kind of tuck it to a 75-degree butt joint if you want more of a positive stop. I usually do 90 because it's easier for me to round. So I just hold the burr flat with a tooth, go straight across, and reduce the enamel however much I need to for my patient to achieve the aesthetic goals. So you see for this patient on the lower photo, we wanted to make sure that we were achieving our aesthetic goals. So we actually made a putty matrix that we could take to the mouth to make sure that we've done enough incisal reduction. And so that way I know that we've achieved our goals. I don't need to take away anymore. The lab has all of this room to add for porcelain. This is kind of showing that butt joint from the sagittal view. So you see we have our veneer preparation here, and then we just have a flat butt joint coming right across on the incisal edge, and the laboratory will make a positive stop there. When I was in dental school and in some of the restorative operative textbooks, they'll show a lingual wraparound margin. So that's the alternative, and we'll show that next. The benefit of this is you don't have to worry about getting that little sliver of enamel here. So this is infinitely easier to prepare than the lingual finish line. So this is what the lingual finish line looks like. You could do a short one, which is a little bit easier that you can see on the left, or a deeper one that you can see on the right. And again, the hardest part of this preparation, if you think about creating your reduction on the facial and then creating your reduction on the lingual, you're left with this little spike of enamel that you have to somehow make smooth. So you're kind of fighting all these different areas of making sure you have a defined margin on the lingual, making sure you have enough reduction on the facial, but also making sure there's no sharp areas in your prep that can cause fracture in the future. The benefit for these is if you're trying to control where your canine guidance is or your incisal guidance is, patients with a very deep bite, sometimes this is necessary. So the only times I ever do this type of wraparound preparation are when I'm trying to control my patient's canine guidance and the patient has a really, really deep guidance. Um, Again, it's harder to prep, it's more technique sensitive. So when I can, I lean on the butt joint margin. A lot easier to do, a ton easier for your lab to fabricate. I can't tell you how many times I've tried to seat one of these and this little wing shears off. And then you're left with, do I remake the veneer and start over from scratch? Do we try to repair it or can we polish it out? So if you can keep that butt joint margin, makes your lab happier, easier seat, easier cement. But again, it's going to be indicated by your patient's guidance. But this I probably do in my practice, and 5% of my cases I'll have a lingual margin. The other 95% are going to be that butt joint margin. All right. So now you've gotten through your preparation and it's time to make your final impression. So the majority of laboratories I work with really like working on a physical stone model. It makes it a little easier to separate the dyes, as well as trying to finish the margins and finish the contacts. With that in mind, I do still do a lot of scanning. So you can do conventional or you can do physical impressions. But before you do your final impression, I would reach out to your dental laboratory during your case planning and ask your technician if they have a preference. Because at the end of the day, this is a true partnership with your dental laboratory. And so you want to make sure that you're getting the best product for your patient that will result in an easier seat appointment for you as well. Whether I'm doing a scan or a conventional impression, I want to make sure I can see all my margins. And so in this case, I usually will do either a 00 or a 000 cord. I usually don't go any wider than a 00 if I can possibly avoid that. Whenever you do tissue retraction with larger cords, you do run the risk of some resulting gingival recession. And I never do. Some people may, I never do a double cord technique for veneers because of that risk. So the cases I've seen that gingival recession in have been double cord techniques or a wider one cord or two cord. So if you use a 00 or 000, it usually gives you the retraction you need with a much lower risk of resulting gingival recession. And typically when you're doing a veneer case, again, it's very aesthetic. The gingival margin is key. And so you want to make sure that you don't have resulting recession at the seat appointment. I will typically do one long cord going all the way across from one side to the other, so I don't cut individual cords. The benefit of that is, again, we're trying to keep that heme to a minimum for the whole process and any inflammation to a minimum. And when you cut all those little cords, you have to dig them out and you can irritate the tissue that way. When you have one cord, it makes it easier to remove and it still does tend to achieve your goals. With veneers, you're usually not wrapping around the lingual. So you see that we're kind of tucking it in interproximal and kind of right here, it's going to go around and then the same thing right here. So you don't have to go all the way around the lingual. We're just going across the facial and tucking it interproximally to visualize all our margins. I usually will use, this is a composite instrument, a Mini 3, and you get it from Hufridi or any of the other manufacturers. And the nice thing about that is it's slim enough and it's flexible enough that you can place the cord without causing that gingival trauma. And so this is the facial view showing the single cord as you go from this side, comes around and kind of tucks in between the margins here and then goes around and finishes. In this case, we were only doing 2 veneers. This was a patient that had had composites on 8 and 9 after a trauma, and they kept staining and debonding. So we wanted to do a more permanent solution. So we did porcelain veneers for him. He was happy with the color, size, and shape of his adjacent teeth. So we only did 2. And again, this was what we established in our treatment planning and with our trial smile. He knows that he can't, they have to match the rest of his teeth. If he does any whitening, the veneers will have to be replaced, or he'll have to end up veneering more teeth after that. We want to keep everything nice and dry so we get our good impression. When I do a digital impression, if it is subgingival a little bit, I will place a cord when I do my scan and make sure the margins are visualized. I mentioned that a lot of technicians like to do physical impressions to have those to work with, especially for my prepless cases. Sometimes we can get away with these digital impressions, or if we have a very nice slice prep with very clear margins, I'll do digital impressions too. The ones I like to do physical impressions for are kind of the minimal prep where it's going to be really technique sensitive to try to section those dies that way. The accuracy of scanners is fantastic. They've many studies showing comparable to physical impressions for crown preps. Not as much evidence in the literature on veneer preps, but kind of the same process. So I would assume similar results. There are a lot of things that can affect your accuracy of your scan, including ambient light, even the room temperature, make sure everything's calibrated. But truly, you want to make sure at the end of the day that whatever impression you use should be nice, clear, crisp, give the lab all the information they need. So when you look at the scan, you look at the physical impression, you want to see your margins, you want to see your proximal contacts, you want to get your opposing, and you want to get your interocclusal record. One of my favorite things about doing the scan, whether it's for a crown or a veneer, or onlay or whatever, I scan for pretty much everything, is the ability to have that real-time communication with your technician. Prosthodontists, my best friends are all lab techs. And so in my veneer cases, we start off together. I'm really interacting with them. What kind of pictures do you want? What kind of material are you thinking? I always have a digital preview for my smile design if I'm not doing the smile design myself, so that I can say, can you make these teeth a little wider? Can you soften the line angles? Really interacting with the technician so that my input is there, their input is there, and we kind of come to that home point together. When it comes time for preparations, I will scan while my patient's in the chair, send it to my tech, and call him before I dismiss the patient. And I will ask him, I'm like, what do you think of this? Can you see everything you need? Do I need to touch up any areas? Do I need to rescan anything? And my technician will see, a lot of times I'll do a go to meeting or something where he can actually control my screen and rotate my scan around, or I'll send it to him and call him and we'll look at it together. So I'm on my screen, he's on his screen. But make sure that they have all that data they need. And I think that's one of the more underutilized aspects of having an intraoral scan if you're outsourcing and not keeping everything in-house, is sending it to your tech, getting them on the phone and saying, what do you think? And especially with these big veneer cases, it can save so much effort if you don't want to have to take your veneer provisionals off and rescan. That is not a fun day. So before you provisionalize, before you send the case, before you send the patient out, have your lab tech take a peek at it and make sure they have all the information they need. This is just showing patient preference is always more ideal for a scan than an impression. I have one patient I've ever had that said they've really loved having impressions made and requested not to be scanned. But that was literally a one patient out of my whole practice. It's more efficient. They've shown kind of that time in the chair, how to get a good impression, especially with a full arch and especially with a big case where it's very technique dependent. Something else that's cool now is we're starting to be able to incorporate 4D scanning, which adds motion to the conventional 3D scan. So this is this equipment in particular, this one's called the Mod Jaw. There are others available too, but basically Now, you take the 3D scans, you pull it into the software, and we can now see the patient's envelope of motion. So same thing, you can add a face scan, you can just add a full face photo. Everything gets merged together. So these are my teeth, and so you can see which teeth touch, which teeth don't. This will show you the intensity of the contacts. And as you have your patient move forward, backward, side to side, you can actually get their envelope of function here, and show their jaw movement and that Posselt's envelope. So you can see how the patient's moving, how their canine guidance is, and that helps you transmit that information during your diagnosis and treatment planning. You can also, if you have a lab that has the ModJaw software, they can actually use that to design with you. So now we can go through, you can do a digital wax up and go through that envelope of motion, of the patient's actual envelope of motion, and you can make sure that the veneers, for example, are in compliance with it in the condylar angle. And so really exciting stuff. This is not yet routine, but certainly it's so exciting to see kind of the next phases of where treatment planning is going and how much information we can incorporate from a digital standpoint and from our virtual patient. So no matter how you do your impression, whether you're adding a mod jaw, you're doing a scan, you're just doing a conventional impression, you need to communicate that shade to your laboratory. And so you see we have different shade tabs here. We have Vita 3D, we have regular Vita, but we want to make sure that we see the name of the shade tab and that we have it in the correct position. Two most common shade tabs are going to be Vita Classical, A1 to D4, and this just kind of goes through uh, what they have, or how they're defined. They go from A1 to D4. The A's, B's, C's, and D's are defined by their innate color, which is actually the hue. When you're matching veneers, like a single veneer especially, what makes one veneer stand out for one another is actually going to be the value. So when you think about color, you have hue, value, chroma. Value is going to be the brightness, darkness. So you're cranking up your screen, whether it's whiter or darker. Uh, that's the value. The hue is going to be that innate coloring. So whether it's yellow, red, gray, brown, blue, whatever. And then the chroma is going to be the intensity of the hue. So as you go from A1 to A4, the chroma becomes more intense within that same hue. So A1 to A4 all have that same hue, that reddish brownish, but A1 has less intensity of the chroma and A4 has more intensity. These are not arranged in value, and so a lot of times you'll see some offices will reorder the shade tab. So rather than be ordered by hue, they're actually ordered by value. The Vita 3D Master is arranged by value. So this one's a little bit easier to see when you're trying to do a small color match for a single veneer. This is going to be more critical than for a full set of veneers. And so you can start to see how these are arranged that way. It doesn't matter really which shade tab you use, as long as you're communicating well to your dental laboratory and you're getting a lot of photographs. Another thing that you want to communicate in your shade match is not only the color you want the veneer to be. So let's say I want my veneers to be a A1. Um, I also need to tell the laboratory what color the underlying substrate is. So you can imagine if you have an implant versus an endo-treated tooth versus a patient that's whitened their whole life, the color of the tooth underneath the porcelain is going to vary quite widely. And because a lot of the ceramics we work with are so translucent, it's critical that the technician knows what color they're trying to mask. And so when you look here on this natural dye material, the lab can actually make dyes that are the colors of these stumps. So if my patient is an ND1 on their tooth, it's going to be a lot easier to make an A1 veneer than if my patient is an ND9. And the lab can use an A1 porcelain, but if you have one tooth that's this color and one tooth that's this color, it's going to be impossible for the lab to match those with a porcelain alone. So not only do we want to say the color we want, but what color the teeth are after we prep them. We also want to communicate any sort of special effects we want to add to the veneer. And so this was a case I was working on with my technician where He actually came in and did the shade match with me. And so he was kind of marking where the patient had a halo, where he might add a little bit of translucency, but the base color here is a 2M1. But you can see at the incisal edge, it's a 1M1 in this kind of little area here where he has the mamelons drawn. So kind of knowing these things and communicating that to your patient, this is a much different resulting veneer than if I just on a lab script write A1. However, if I'm doing a single veneer on a high smile, high aesthetic patient, I might go with my technician, we'll draw this together. If I'm doing a set of veneers, of 10 veneers on a patient that just wants something very uniform, A1 might be adequate. So kind of knowing your technician, knowing your case is going to really show you how in-depth you need to be on this shade match. So here you can see this patient in this photo on the left has three different underlying substrate colors. So we have three different shade tabs. And we can start to choose that final shade on what is going to be the best for that case. You want to try to get the initial shade and the prep shade when the tooth is as hydrated as possible. A lot of times that's really hard after preparation. So you want to do your initial shade match before you prep. Then you want to do your next shade match after you prep and kind of, again, communicating with your lab tech that whole time. One thing that I'd love to point out in both of these photos is you can see where the shade tab is sitting adjacent to the teeth. So we have the edge of the shade tab directly in contact in the same plane as the tooth itself. When you move that shade tab anterior to the tooth, then it creates this false coloring where this actually looks brighter than this. And if you alternate and do it this way, now this one looks darker than this. So if you're taking your shade tab photos with your tab way lingual or way facial to the tooth, you're not communicating to your lab what exact shade it is. So to me, this is such a key photo. If you can kind of burn this image in your mind where you have the shade tab actually edge to edge, incisal edge to incisal edge with the patient's tooth. That puts them in the same plane. The light reflectance is the same, and it's not going to create any false brightness or darkness. All right, so now we've done our communication to the lab, we've gotten our photos, we've gotten our final impression. Now we're going to provisionalize. And what we're showing in this photo, and I think this photo is worth 1,000 words, is that the patient can clean between their veneers, their veneer provisionals. So the goals of our veneer provisionals, we want to test phonetics, aesthetics, and function. So with the trial smile, we kind of got that initial idea, but the patient didn't wear that home. So they couldn't chew with it, they couldn't function with it, they couldn't see kind of what that was really like. This is great for laboratory communication. If you do a lot of adjusting for occlusion, I have a lot of really complex occlusion cases where I will home in the occlusion in the provisionals while the patient's in my chair. I scan those and send that to the lab. So now they have a template not only for the aesthetics, but also for the incisal guidance and the function. It'll protect the tooth during function so that nothing chips, and it maintains the patient's occlusion and keeps teeth from shifting. We are going to make our provisionals very similar to how we made our trial smile. So same matrix, same temp material. If you don't have a lot of undercuts, a lot of times you can set that in and take it out. The trick that I tell my second-year dental students, as well as my third and fourth-year dental students, whenever they're making provisionals and having trouble with things locking in, whether it's a veneer or a crown, I load it with Luxatemp, I seat it, I set a timer for exactly 60 seconds, and then I take it out. At that 60-second point, it's usually set enough that you can take it out without breaking it, but it's not so set that it locks in. So it's like 60 seconds is the magic number. If your office is hotter or you practice in Fort Lauderdale or somewhere a little more lovely, you might want to change that to like 54 seconds. But in North Carolina, 60 seconds is the perfect amount of time. When you're trying to get that sweet spot on the provisional material that you can take it out and not have it break. You can trim the excess with whatever your weapon of choice is, whether it's scissors or a high speed or what my students affectionately refer to as the death wheel to get the excess material off. Now you have a set of provisionals that's basically like a crown provisional, and that can be bonded into place. So again, to kind of summarize, you can lubricate the teeth if you want, or you can just sometimes I just make sure that they're not totally dry. Seat the material over, remove it, contour it, and go ahead and polish it, cement and then polish. When I cement, if there's not a lot of mechanical retention, if there's no undercuts that we're locking into, we'll do what's called a spot etch, and that's literally taking one drop of etch right in the center of the tooth. You do not want this on your margins. I repeat, you do not want the etch on your margins. So that's why we're trying to get in the center of the tooth as far away from all the margins as possible. And then I just take a wet 2x2 and wipe that off. I don't blast water everywhere because I don't want that etch to run onto the margins. If your patient really has a heavy occlusion or you're concerned about them not staying, you can also spot bond. So you can add a little bit of bonding agent right in that exact same spot. And then from there, you can cement your provisional veneers. There's a lot of different cements you can use. It says resin-based cement. It should be a resin-based provisional cement. They actually make veneer provisional cements from different companies. You can also just use a regular flowable resin. Because you're not etching and bonding around the margins, it will pop off there. So you can either use a flowable resin, seed it and cure it. You can use a resin-based provisional cement. I used Temp Bond Clear. You can use any of those cements like that. You do not want to use anything with eugenol in it. So if you use a Temp Bond, make sure it's a non-eugenol. Any of the provisional cements you use, if they're that bright white, make sure it says NE or non-eugenol because that will affect your bond strength. The same goes for your when you're bonding crowns. So if you're bonding porcelain crowns and you're having issues with them debonding, double check your provisional cement because if you have eugenol in it, it can affect that bond strength at the time of cementation. And then you're going to remove the excess. Make sure that your patient can floss in between their teeth. Make sure there's no excess at the margins because that can actually induce a gingivitis depending on how long your patient's wearing your provisionals. And then you will cure. I like to just really make sure those margins are clean, make sure that they're cleansable so that when your patient comes back for bonding, that their tissue is as healthy as possible. I love these ET series of burrs. I don't know what ET stands for, but it's like ET 3, 6, and 9, depending on the length. And then they have fine, super fine, and ultra fine. I think it goes from fine to super fine. And that depends on the flutings. It's like a 6, 12, and I can't remember. I should know the fluting. But the fluting gets finer and finer as you go through here. The reason why I like these ET burrs is they're safe end cutting, which means that these tips are rounded so that when you go to finish up and get rid of any extra cement, that you're not gonna tear up your gingival fibers or induce any bleeding or any recession. So you want a safe end cutting burr like these ET series. I know this one's 8 and this one's 30. I can't remember how many flutes this one has. Maybe someone can type in what the yellow flutes are in the chat. So summarize cementing the provisionals. If you're trying to get that mechanical retention, you can do a spot etch in the center of the tooth, use a provisional veneer cement or a flowable resin. Make sure everything is clean as possible before you cure that. After you cement it, make sure all the margins are clean and cleansable and that there's no cement up underneath the margin that could induce any gingivitis that can compromise your seat date. If you did a lot of changes to the diagnostic wax up, or if you had to do a lot of occlusal altering, an impression or a scan is really, really nice to send to your laboratory as a guide, because then all those changes you incorporated now can be reflected in the final. And I've had that happen a few times where we think we're great with a wax up and then we try it in and it's a little too long, whether from an aesthetic or phonetic or functional standpoint. And so adjusting that chair side and scanning that and communicating to your lab makes the next step more predictable. An alternative provisional technique that I think might even be a little easier is called the shrink wrap technique. And basically, you're not taking the provisional off and then re-cementing it. So you're kind of locking it into place during this curing time. So it starts with the same process where you have your matrix filled with a bisacryl, you seed it, and you let it polymerize all the way to finish. Before you seat the matrix, though, you'll do your spot etch right in that same spot, and you can apply a little bit of bonding agent like we talked about. So spot etch, spot bond, and then seat the material. Um, you don't take it back out until the patient comes back for veneer seat. So after the provisional is made and intraorally, you'll go around with either a scaler, a scalpel, or that ET carbide burr and smooth to make sure that everything is um, cleansable for the patient and that you don't have too many areas locked in. So in this one, they're easier to make. They're easier to make to keep them in place, but they're harder to finish. The other technique where you make them indirectly and then re-cement them, they're a little bit more technique sensitive to make, but the finishing is a lot easier. All right, made our provisionals. We sent our patient home. They survived the 2 to 3 weeks in veneer provisionals, and now they're going to come back for the try-in appointment. I always tell my patients when they're in veneer provisionals to watch their diet. I say treat it like you're in braces because we have such a strong final bond to enamel on the final veneer, but the veneer provisionals are kind of held in with a prayer and a little bit of cement because you don't have that mechanical retention that you do for conventional crown and bridge. So you're kind of relying on, again, on that bonding. But because we're not etching, we don't have that really nice bond. So again, provisional phase can be unpredictable for veneers. So try to make sure your patient has a sheet that says what they can and can't eat. Anything, if you do ortho in your practice, it's the same foods and the same dietary restrictions with veneer provisionals as with brackets. All right, the try-in appointment. So at this appointment, before we permanently bond these veneers, we want to make sure that the patient is happy, that they fit, that our goals are met, that their goals are met, and that everything is ideal for our patient. So the first thing we're going to do is remove the provisionals, and that's going to depend on whether or not you did the shrink wrap technique or whether or not you did the indirect bonding technique. If you just cemented them as one piece, or you take it out, finish it, and cement it, the first technique, those just pop off. Usually what I'll do is I'll take a cotton roll and have my patients grind on a cotton roll and it'll break that cement seal. It makes a horrible cracking noise when the plastic chips, but they almost always pop right off. If you did the shrink wrap technique, you're probably going to have to do a little bit more effort. Sometimes you'll have to use a hand piece and section them out in pieces. Sometimes you'll use a scaler and have to go that way. But the shrink wrap provisionals are a lot harder to remove generally than the indirectly bonded provisionals. Then we're going to want to pumice the teeth. I recommend using a flour pumice, a plain flour pumice, because fluoride can impact the bond strength. Again, you're not having a lot of fluoride imparted, but we want to have everything in our favor when we do veneers. So flour pumice without fluoride is going to give you a slightly better result. Get everything rinsed and clean. If you utilize a veneer provisional cement, a lot of times they are made to glow in the UV light, so you can kind of shine your curing light and see where little pieces remain, and you can scale those off. If you spot etched and spot bonded, you're going to want to clean the area that was spot bonded as well. I'll just take a fine diamond or a soft flex disc and just polish off that little spot of bonding. And then we're going to try in our veneers. And so you can see here at this try-in appointment, on that veneer number 8, either the patient had a little bit of gingival recession after we made the provisional or made our final impression and the tissue shrunk back, or the lab may have over-trimmed the die. And so when you have a case like this, you may be able, if the lab used a feldspathic porcelain, you may be able to add, or a pressed Emax, you may be able to add a little bit of ceramic there. If this was a milled or a zirconia, then you're going to have to re-impress and remake that veneer. Again, it's kind of risky whether or not you're going to add a margin to porcelain. I would only advise doing this if you have an in-house lab, or if it's something that you feel comfortable doing yourself. when I was in private practice, we had an in-house ceramist that used to do this for us chairside so we could evaluate it together, whether it was an addition or a remake. Now that I'm outsourcing all of my veneers, I would re-impress this case and send this one back for a remake. You still want to try in to make sure that everything else is good. So we want to check the shade, check the incisal edge, the midline, and all the other margins to determine if everything else is adequate and how many changes you're going to make. This is also a very common thing that happens with porcelain veneers. So when you think about the shrink wrap technique and it's locking interdentally to hold the provisional in place, it's pushing on that papilla. So when you take the veneer provisional off, you end up with this kind of compressed, strangled papilla that got smashed down. So even though when you took your final impression, there was no black triangle, now that the provisional is off, you've induced kind of this black triangle between the two veneers. And the majority of time, that papilla will refill, usually within a matter of a week or two. But depending on how long the provisionals were in place and how aesthetically demanding your patient is, you might need to add some ceramic here to close in that black triangle. So again, this is just kind of showing the importance of a really well-made, well-polished provisional veneer. When you do the try-in, a lot of times we have our patients sitting down in the chair, kind of sort of reclined, and we give them the mirror. My assistants always hand them the mirror on the side that's really zoomed in, like the magnifying side. So they're looking magnified kind of sideways at their veneers, and we're asking to evaluate these aesthetics, but they never look at themselves that way, nor do most people look at them from that angle and at that magnification. So if you have it set up in your office where you have a wall mirror, my recommendation is before you hand them the sitting down mirror, have the patient stand up and look at their smile in the big mirror, because this is how they're used to seeing themselves standing in the mirror, and this is how most people are going to interact with them. So my recommendation is, again, if you can, in your operatory, if you have it set up in a way that they can stand and look in the mirror, they're going to get a more realistic view of what their veneers look like than if they're reclined in a chair with a mirror 2 inches from their face. This tool on the right called a right light, there's a lot of other different brands too. That's a little clicker that you can go through daylight, sunlight, office light, fluorescent light. And so you can kind of click through and see what the veneers look like in different lights and make sure that the color match is really good. When you cement veneers, you'll use a light cure resin cement. And usually they have kits that have all different shades in them. And so this is a kit that comes from one of the cement manufacturers, and these are the 7 shades of cements that they have. So they have a warm shade on the left, they have a bright shade on the right, and they have a translucent shade in the middle. When you're working with feldspathics, or if you're working with a prepless veneer or some of these ultra thin ceramics, the cement underneath it can make a huge difference in the final coloration. If it's a zirconia veneer or a very thick veneer, or the patient's not doing a big color change, a lot of times these won't matter, and you can just go with a translucent shade. But it's amazing how the light will refract differently with these different resin cements. In this case I'm showing in the middle, this was a case where we had we were doing a single central veneer. And so the shade match made a huge difference when we went from the warm to the cool. So that's called a try and paste. One thing that I will tell you is please look very carefully, because the try and paste tube looks very similar to the permanent cement tube. You do not want to mix those up on either side. So when you're trying to choose your corresponding cement shade, you'll use the try-and shade that matches. And this is really nice because you can actually try in the veneers with 3 different colors of cements. And if your patient has high aesthetics, sometimes they'll have a preference to the warmth or to the brightness, or the translucency. So again, make sure that you try it in, that the patient's happy with the color. Choose the shade of cement that corresponds with the try and paste that you like. Not all cements come with different shades, and not all of the cements come with try and pastes. So if it's a translucent cement, there might not be a corresponding translucent try and paste because it's going to look the same um, with the translucent try-in as it does, or the translucent cement. If it's a cement that has a whole kit with varying colors, that's usually when you'll have the try and paste, which is really, really nice if you're doing a lot of aesthetic cases and a lot of veneers. So after you do your try-in, you want to get back to that nice, clean porcelain. So you'll use the only product that I know on the market like that is going to be called Ivaclean. There may be others by now, but basically what this does is it removes phosphate groups that you find in the saliva. So it takes all of that debris and contamination out and allows you that more predictable bond before you cement your case. All right. So now we've done so much hard work, right? We've done our diagnostics, we've done our preparation, we've done our final impression, we've done our shade match, we've survived the provisional phase, we've gone through the try-in, and we've picked our favorite cement color. Now we're finally ready to bond that veneer. So we have to treat here both the veneer as well as the tooth. So I'm going to have a big asterisk, an oral asterisk, because I don't have it written down here. But this protocol is going to vary depending on the type of cement you use, as well as the type of porcelain you use. So if you read the instructions, if you do a feldspathic veneer, usually you're going to want to etch those for up to 60 seconds. An Emax veneer, you're going to etch for 20 seconds. A zirconia veneer, you're not going to etch at all. So I'm going to go by the cases that I'm showing here is going to be a lithium disilicate case. That's kind of the most common veneer material right now. So you're going to put a phosphoric acid etch. This is not the same etch that you use on your teeth. So we're going to use, I'm sorry, this is a hydrofluoric acid. This is a hydrofluoric acid etch, not the phosphoric acid that you use on the teeth. The hydrofluoric acid is much stronger, and it will etch that porcelain. You do not want to use the hydrofluoric intraorally, and it says in all the warnings, do not use this intraorally. So hydrofluoric is extraoral on the veneers, phosphoric is intraoral on the teeth. And the great news is usually all the phosphoric acid etches I've seen, regardless of the brand, are either yellow or red versus kind of that blue or purple that you would see on an intraoral etch. So they're kind to make them different colors. After you etch, the amount of time, depending on the material you're using. So for Emax, again, it's going to be 20 seconds. Rinse that and clean it. And then you're going to use something inside the veneer called silane. Silane is a coupling agent that helps the resin bond to the porcelain. And it's ideal and key in using and having success in bonding. Because again, we're not relying on any mechanical retention. This is only chemical retention. And because we have lots and lots of studies, lots of evidence that makes bonding to porcelain predictable and bonding to enamel predictable, that's how veneers are so successful. And so we're going to silane, you're going to let it air dry. And again, this is going to depend tooth by tooth. There's lots of different brands of silane that you can use. So some of them are multi-purpose where they're only for ceramic or for zirconia, metal, and ceramics. Others are specifically for ceramics. My other big asterisk is usually your dental laboratory will do the etch and the silane. So if you don't have etch and silane in your office, that is totally fine. Just make sure that, again, laboratory communication is key. Before your patient comes into cement, ask your lab to make sure that they've etched and silaned the veneer before they deliver it to your office. So basically steps 1 and 2, treating the veneer can be done at the laboratory or in office based on your preference and your experience. Now you have to treat the tooth. So this one you can't delegate to your lab. You're going to isolate whichever teeth you're planning to bond first and use your regular phosphoric acid etch. Depending on the patient's gingival health, you might want to place a cord. Depending on the number of veneers you do, you might want to place a rubber dam. You might do an isovac. You might have six-handed dentistry. Here we have the retractors that stay in place. Today I'll use an Optragate a lot. So basically you want to make sure that the lips are away from the gingival margins. Everything is easy to isolate. Here in this case, we're only bonding laterals. So we don't want to get etch on the neighbor teeth. Here we have Teflon tape isolating. There's so many different techniques you can use, but keeping those teeth as dry as possible is key for success with your bonding. After you etch, you're going to want to see this frosted appearance on the enamel. Again, we talked about teeth that are harder to bond to and teeth that are easier to bond to. In this case, we have a really nice etch, so everything is great. The problem here is our gingival health right here between 7 and 8. So in this case, we'd want to place a cord, make sure that the tissue's under control, and then re-etch this area here. And then next, we're going to use bonding agent. This really, really, really varies by brand of cement. I've worked with some cements that you don't use any bonding agent at all that is built into the cement. I've used some that you have to use a specific prime and bond protocol. Sometimes you cure the bonding agent, sometimes you don't cure the bonding agent. So in this case, you're going to want to specifically look at the cement you're using and read the instructions really well, or ask AI to read the instructions to you very well so that you know I'm etching the tooth for this long, I'm rinsing for this long, I'm using this primer, this bonding agent, I am curing here, I'm not curing here. What I really recommend is if you can find one product that you like, follow the etch, bond, and cement for that brand. So you're not mixing and matching steps. Because again, if this cement says you shouldn't light cure, but it's recommending you use this bonding agent you're supposed to light cure, this one you're not, that can make that whole process less predictable. So if you can match, I know it says arch, it should say match. If you can match the resin cement to the brand of bonding agent, it's going to help with that. I used to make a little checklist for my assistants so that we had the cure coming when we needed the cure, the brush coming when we needed the brush, because this can be a very high intensity appointment when you're trying to go step by step. And there's so many little steps that I didn't like anything to be forgotten. I'm a checklist manifesto person. So I had a veneer cementing checklist back when I was in private practice, where we would go step by step through the bonding. And I would recommend that you make your own because each cement has a different checklist. So depending on if you're using, for example, the Ivoclar Multilink is going to be different than the one that we use from Ultradent. So again, make sure that you're reading the instructions for your specific cement because they vary quite widely. All right. One of the other things we want to be aware of is that you want to use a purely light cure resin cement. So there's light cure cements and there's dual cure cements. The dual cure cements have something in them called amines, and over time those can discolor. And so if you use a dual cure cement, the veneers will look great right away, but over time they'll get darker and darker and darker. So you want to make sure you're always using a light cure resin cement. The other benefit is this has a longer working time and you have more control over the working time than you do with a dual cure cement. So that while you're cementing your full veneer case, you don't have to worry about the cement setting on you because you control when the light cure comes on. My other word of warning, I will say this is a mistake I learned from a friend and not me for once, because usually I'm learning from my mistakes. If you have a loops with a headlamp, please make sure you turn the headlamp off when you start cementing your veneers, because that was when I was working with a student. It was very heartbreaking. They didn't turn off their headlamp, and we had to cut off a veneer the day of cementation because the cement actually cured from the student's headlamp. So we talked a lot about etch and bond and silane and everything. This is kind of a close-up of that bonded interface. And each one of these steps is so critical for kind of that success. So starting from the outside, we have our etched ceramic. That may be a feldspathic porcelain. It may be an Emax. It may be a lithium silicate. And then we're going to have our silane next. So that's that coupling agent that bonds really, really well to that porcelain. Unfilled resin is going to be your bonding agent. And then we have finally our enamel dentin bond. I'm sorry, your unfilled resin is going to be your bonding agent. Your resin luting agent is your resin cement. And now we have our bond to our enamel. So all sorts of layers. It's going to vary slightly, sorry, but each one of those is going to be key in getting that predictable bond strength to your veneer. Next, in a very long process, we're getting close to the finish line, is going to be finishing. So we want to make sure that we remove all that excess resin. Now remember, this is a resin cement, so it's not going to just flick off with a scaler. And I have bonded more teeth with more materials than I care to mention here, all the way from sealant material to resin cements. I've glued everything together that you can possibly glue together. This tool that I have in this picture right here has saved my life in more ways than I can ever repay it. But basically, when you get your finishing strips from Invisalign or any of your ortho tools, there's one that's like this that doesn't have any grit on either side. So this is smooth right here. There's no sandpaper, there's no grit to do any interproximal reduction, but you have this little saw going across the top, and that saw will get right through that cement. So if this is great for composite bonding, great for sealants and non-compliant kids that get in between the teeth, and fantastically amazing for finishing your veneers. If you have any little tiny speck of resin cement between the teeth, this will save your life. You also want to go with an Explorer and make sure that the margins are super, super clean as you go around all the cervicals. If you have any excess resin cement, you're going to want to take one of those finishing burrs and get rid of that, or a scalpel blade. I don't show any pictures of the 12 blades because I cut myself a lot. So I don't take photos when I'm using those. I tend to prefer using the rotary instruments with the ET carbides. I have friends that are more graceful than I am, and they go with a 12 blade around the margins, and I'm always in awe at how beautiful they are with that. You can use a scaler, anything you can use to just smooth those edges and make sure there's no little specks of cement or no bulbous pieces of porcelain that are going to induce gingivitis over time. So again, this is me using my ET carbide to get rid of any cement, and my ET diamond. I use these ET diamonds a lot with my prepless veneer cases to kind of get that initial, any lumps out of it or anything where there's over bulkiness at the gum line. Once all the cement is clean, last but not least, we need to make sure that the occlusion is good. So the goal is to have as many contacts as you can in protrusive and excursives. Because if you think about ideal canine protected occlusion, when the patient chomps in the back in centric relation, we want our dots in the back, right? So we don't want a lot of contacts on the anterior teeth in centric relation or MI. But when they start moving forward, backwards, side to side, we are going to want some anterior guidance on the canines and centrals. If we have heavy guidance on one tooth, especially going into protrusives, then that can cause some issues with debonding. So you want to make sure you have a nice balance as you go through your protrusive and excursives. The other key that is super important is where your contacts are when you're in MI, CP, or maximum intercuspation. So when you have your patient chomp, 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 you want to see the dots either on porcelain or on enamel. We start to see issues with debond when you have contacts right along that junction of where the porcelain and the enamel is, because then you're going to have start to introduce weakening or fracture right at that margin from the repeated cycling. So when you have your patient tap, 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 or chomp, 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 or whatever verb you utilize in your occlusal technique, you want to make sure that you see your dots on enamel or on porcelain, not at the junction. And last but not least, I like to make my patients a stabilization splint. For veneer cases and makeover cases, I do maxillary splints. If it's a different type of case, I may do a mandibular splint, so I'm not always maxillary everything, but particularly for veneers, if you think about the function at night, if somebody has a slight bruxing habit, a maxillary stabilization splint is going to give a little bit of kind of bracing effect to those veneers. The prognosis of veneers is very good. There's a wide range of survival rates available. They say that the average is about a 10-year. We usually tell our patients that we can expect them to last 10 to 15 years. again, this study showed at 5 years a 98% success rate, at 15 years a 93% success rate. But 10 years is a nice estimate to say it's a little bit higher than what we tell patients for crowns, which is 6 to 10 years. So slightly higher success rate than full coverage crowns. But sometimes they do fail. So even though very, very high success rate, we do sometimes see failures, as with any restorative dentistry. And these are our main modes of failures that we see. The first is debonding. Almost always when I see debonds, it's either a patient that has an occlusal interference that we didn't catch, or they don't have a lot of enamel to bond to, and we're having an unpredictable dentin substrate. So if you look at this picture in the middle that's debonded, you can see that there's some enamel here on the incisal portion of the tooth, but that cervical portion is mostly dentin. And this is a patient that had come in frequently for debonding. If it continues to happen, you can either continue to cement it, or you can diagnose that the patient would be better with a crown so that this doesn't continue to persist. I show some fractures in these two lower photos. I worked at a practice where we did a lot of veneers for a number of years. So I was doing follow-ups on decades-old veneers. So a lot of these were made with a feldspathic porcelain that's not as strong as the ceramics we use today. So when we look at lithium disilicate or even lithium silicate, we're seeing a much better fracture toughness. I'm going to knock on wood and say that I have not seen a fractured Emax or lithium silicate veneer in my practice. All the fractures I've seen were older feldspathic veneers. The failures I've seen with Emax are either going to be a debond, which again is usually occlusion or lack of enamel, or what you see up top, which is kind of that recession or discoloration at the margins. So in this case, we have some gingival recession that happens over time with life. I say with wisdom now that I'm in my mid-40s. But we tend to see that recession over time. Really, the only solution would be to either replace the veneer or do some sort of patchwork. So usually at that point, when it becomes an aesthetic, it's not a functional issue because these margins are closed. We just have some recession. It's just an aesthetic issue. So at that point, we leave it up to the patient to say when they feel prepared to move forward. So to avoid all those things, again, we try to maintain as much enamel structure. We talked about that a lot, but again, it's so important. Enamel is key to successful veneers. We want to try to manage occlusion as best as we can. So contacts on the enamel, not at the junction, nice balance. Make sure you set the patient up and check your eccentric relation, or sorry, your MICP sitting up as well as reclined. And also make sure you have your patient move forward, backward, side to side, go through all the excursive sitting up and reclined to make sure you don't have interferences. When in doubt, make a maxillary splint to protect them at night. And then hiding the margins as best as you can, so tucking them interproximally, keeping them epigingival will help with that as well. And also cord technique, not using a lot of cords to pack. All right, let's close this out talking about dental materials. So we have a lot of different options available today. Feldspathic was the first material that we really used for porcelain veneers. We then used some lucite material, which we don't really use as much today. And now we have either lithium disilicate or lithium silicate or LISI, and then also zirconia. So as we look at this, when you go from feldspathic to zirconia, you see the flexural strength increasing greatly. So I showed you some of those failure cases. Those were all feldspathic, which is here with a flexural strength in megapascals of about 60 versus up to 500 that we see with lithium disilicate. So you can see why the fracture rate has decreased so much as the materials have improved with flexural strength. The downside is, as the flexural strength has gotten better, the translucency has not. So when you do a zirconia veneer, it's going to have the least translucency. Feldspathic is going to have the most translucency. So you're giving up translucency as you add that flexural strength. And you can even see that within the generations of zirconia. So when you look at a 3Y, which is a 3% yttrium zirconia, it's the high strength, like think Bruxer type crowns where they're very opacious, versus a 7Y or a 9Y, you're going to have that nice translucency built in as you transition to the cubic zirconia. But as you do that, you're really affecting and compromising your flexural strength. So any material you're working with that has higher translucency is likely going to have lower flexural strength. This is a really quick table. If you want to grab a screenshot, you can. Otherwise, happy to share this as well, that just goes through the different systems and manufacturing techniques. And just kind of summarizing, again, as fracture strength decreases, not only does translucency decrease, but also bond strength. So working with feldspathic, you're going to get the highest translucency, highest control over aesthetics, the best bond, but significantly lower fracture strength. So that's why Emax is kind of that most popular choice right now, the lithium disilicate for porcelain veneers, because it's right in the middle of fracture strength, bond strength, and translucency. So it has a really acceptable, nice translucency and aesthetics. It has a very predictable bond strength, and it has a really nice fracture toughness. If you want to go higher in fracture toughness, you're going to be looking at zirconia. If you're going to be looking at higher aesthetics, you're going to be looking at feldspathic or a lucite reinforced or something like that. But again, you're always kind of giving and taking between the fracture toughness, the bond strength, and the translucency. And Emax lithium disilicate is that nice, sweet spot in the middle ground. So if you're just getting started with veneers, that lithium disilicate's a nice, safe place to live where you're not going to have a lot of technique sensitivity for your bonding protocol, for your fracture toughness and case selection, and you're still going to get acceptable aesthetics. And so just to kind of go through those again, this is going to be feldspathic porcelain. Those are almost always hand layered when you make them out of veneers. They're not strong enough to mill a veneer out of. They're hand stacked by ceramists. So if you're working with a high-end ceramist, really high aesthetic patient with a high smile line, doing one or two single veneers, feldspathic with a ceramist that can come meet your patient is kind of that ideal situation for that. It does, however, we talked about the fracture toughness and the flexural strength. It also is incredibly abrasive. So when you think about all those patients you've seen in your practice that have those old PFM crowns on the top, that have worn the lower interiors down to nothing, that's feldspathic porcelain. So the same material that's on those old layered PFM crowns that caused that incisal trauma to the lower or incisal wear to the lowers is the exact same material for your veneers. So you want to think about that long term. If you're doing feldspathic veneers, you want to make sure you control the guidance so that you don't cause damage to the opposing dentition. This is showing the lucite reinforced and lithium disilicate, that kind of middle ground area. Nice sweet spot for aesthetics, function, and strength, as well as bondability. That can be milled or pressed. So it also gives a little bit of flexibility to the ceramist if they feel more comfortable with hand stacking versus machining or milling those veneers. And this is just reinforcing that. The lithium disilicate you can also use for the ultra thin veneers as well as the conventional veneers. So it's also versatile on the technician end, depending on how much preparation you've done for your patient, whether it's a minimal prep or a no prep or a ultra thin veneer. And we'll finish up by talking about zirconia. Zirconia has the lowest translucency, but also the highest bond strength. And there was the highest flexural strength. There was some question about the bond strength of it. So there was a whole argument in the prosthodontic world of probably about a decade ago, where some people said you cannot bond zirconia, some people said you can bond zirconia, and it was a really it was a really cool battle to see among the prosthodontists. Ultimately, we have decided officially that you can bond to zirconia. There is plenty of evidence to show. So let's walk through a case, kind of start to finish. My patient came in, he had a bilateral cleft lip and palate, and so that was all repaired. And so on the left side, he was missing his lateral incisor and had a 3-unit bridge, old PFM 3-unit bridge. On the right side, he had some composite bonding, some direct veneers, if you will. And you can see over time, they've lost their luster, they've picked up stain. That's kind of the biggest downside to doing a direct composite veneer is they don't maintain their luster over time. They do stain over time, and they don't have as much longevity as a porcelain veneer. What is interesting is, and I'll show you on the x-ray, that the roots were actually fused here on 9 and 10. So they kind of would join and then divide. So not really a great candidate for conventional crown preps. And so you can start to understand why the clinician chose to do the bonding rather than the initial restorative work. So we go tooth by tooth. The teeth we're looking at restoring are 6, 8, 9 through 11. We look at the restorative prognosis, the perioprognosis, and the endoprognosis. We never know what we're going to find for underneath the PFM bridge, so kind of erring on the side of we don't know yet for restorative and perioprognosis. And so this is, again, showing those x-rays, and so you can start to see where the roots kind of fused, where that cleft is between 9 and 10. And you can see our 3-unit bridge here on 6 through 8. And so his main concerns were he was always very self-conscious about his smile. His daughters were graduating high school, and so he wanted to have his smile done so that he could smile at their graduation and feel more confident that way. So we do our digital smile design. I talked a little bit at the diagnosis section about the two-dimensional smile design. That's what you're looking at here on the right-hand side of the screen. So this is just an AI-generated tooth setup based on the proportions that we decided here. This is not something that can be directly disseminated into a 3D wax up. It's just something to kind of play with and start to show patients some responsibilities. It's a lot easier to do, a lot lower cost. There's free apps. This is actually built in on some of the scanner software. So if you have a Trios, this smile design is actually built into the Trios scanner itself. So here we did our digital wax up, and we do our trial smile or the test drive. And to see what we wanted to, if we could achieve our goals, this is with the 6 front teeth. When he smiled, he decided he wanted to do the whole shebang. So we actually ended up adding no prep veneers, 2 no prep veneers on each side to complete his smile. So again, this is kind of the benefit of the test drive. He wanted to whiten. When I showed him what it looked like just 6 through 11, which was our initial plan, you can see 6 through 11 now kind of pop and the smile drops as you go back. So we did decide to add 2 more veneers on each side. Here is our preparations for the anteriors. So you see we did conventional crown preps on 6 and 8 for our bridge. Make sure we have a nice path of draw. Those were a retreat, so I didn't have as much control over kind of the taper and everything else. And then we removed our composite and kind of finalized our veneer preps here. I want to stay above where those roots join together. And you'll notice he has a lot of recession here. So just kind of keep that in the back of your mind. If I had to decide where we're putting our veneer margins on 9, 10, and 11, right? Because we want enamel to bond to. This big class 5 defect area is not enamel. This is cementum and or dentin, depending on what part we're looking at. So if you look at where the veneer margins are on these teeth, they stop right above that CEJ. So we are stopping our veneer margin on the enamel. So our veneers are 100% on enamel on these teeth. We decided to do zirconia because I'm doing a full contour zirconia bridge on the right side. So we're going to do zirconia veneers to match. We talked about the bondability of zirconia. There's a fantastic sequence that's pretty easy to remember now called the APC concept, where you're going to do airborne particle abrasion inside the veneer, find a zirconia primer. It has to have NDP in it. So this is not silane. This is, look for these letters MDP, and then we're going to use a resin cement. So this is our final case, bonded in. You can see we have our bridge seated. We cleaned it all up. We seated our veneers. You can see we are stopping short of the CEJ. So we still have these exposed root surfaces here. We've added our extra veneers on each side, or no prep veneers. And then I have my restorative colleague, my general dentist colleague, Dr. Esfandiarinia, who is amazing. And we actually used a pink composite apical to those margins to cover that up. So they have several different brands now of these pink composites. Some of them have glass ionomer in them. So there's a resin modified glass ionomer version. There's a straight composite version to improve bonding. So now I have nice solid margins all in enamel, but we've achieved the patient's goal of covering that up with our custom class 5 bonding. So to summarize, veneers can be a very minimally invasive procedure if you do minimal prep, guided reduction based on your trial smile. Super life-changing. Patients love them. But accurate diagnosis is critical. So kind of doing all that planning on the front end makes each step more predictable as you go down the line. I love doing trial smiles for my patients. I do them for removable, for implants, for veneers, for fixed. They help kind of serve as that blueprint for the entire process, start to finish. Last but not least, the most important step is the step that you're working on. So if you're bonding's the most important step. If you're cementing or if you're prepping, that's the most important step. If you're doing your impression, catching those margins is your most important step. So each step of the sequence is absolutely critical.